All right, so here is my presentation on health economics and athletic training, how to demonstrate your value. So I'll actually be presenting this at a MATA DCATA Joint Conference this Saturday, January 24th. So this is actually my practice run through, but I plan on kind of, posting this on the podcast and socials, especially anyone in healthcare, especially athletic trainers who are interested in this topic. So here we go. Oop. Let's try that again. There you go. All right, those are my objectives, but really the biggest goal, you can read through them, right, is how do we demonstrate our value from a money standpoint? So we'll go through health economics, what it is, some pertinent literature as it pertains to health economics and athletic training, and then I'll go into my own individual example and how I do it currently at my high school. So disclosures, conflicts of interest, none. I have zero. In this setting, I am just an athletic trainer at a high school. Not just, but you know. So before we even get started, I just want to point out I was ahead of the curve. This journal just came out this past month, Journal of Athletic Training, and this whole issue is actually on the topic I'm going over today. I cite a lot of the articles here, plus some others. Highly recommend going through this if you have an interest in this topic. Right, and then that's just the line of where we're at. So how did I get here? As you know, economics, you're going to think money. I'll be perfectly honest. When I first started out as a college athletic trainer, I didn't really care about money. I was, hey, I'm having a good time. I'm learning. I'm doing all the cool things. And then I think what happens with a lot of people is COVID happens, and you sit back and you think like, okay, like what is my job safety, security? How can I show what I'm actually doing at work? You're seeing people get furloughed left and right. So I started going through this, how do I do that? And that's kind of when I started coming across, oh, what you should do is show people how to, what it would be like if they went to an outside service and bill. So, in the EMR that I use there, Sportswear Online, I started, heavily documenting and showing and kind of showing everything I was doing, put a price value to it, eventually brought it over to my boss, and it was just kind of like, okay, that's nice. Anyway, so still in the college setting and kind of was getting the sense of I don't know if this is really for me. I feel like I'm getting a little stuck. I still got the still did the salary negotiations and the job promotions and whatnot, but it really it just felt like I wasn't growing enough, getting quicker, big enough, and it felt like we were struggling to kind of show the value there. So I ended up actually starting an MPH program while I was at the University of Delaware. That really, honestly, it was a good change of pace for me. At the time, I just felt like I wanted to help more than just athletes, and the Master's Public Health program kind of gave me more of a statistical research background than what I currently had at that time. And I really had a good time in it, but it also kind of showed me how to kind of start showing value. So I ultimately left the college setting a little bit. So you just want to do something else in the college setting. It was just very time consuming and it's not as much money. And so I ended up actually in the industrial setting. And I was only there for 6 months. Ultimately, I got bored. But the biggest thing they did was this idea of demonstrating your value of, hey, we provide this service. This is the amount of money we're saving you. And so, I kind of took all my experiences and now I'm at a high school where, I feel like it's truly like a full blend of everything I do. And I have the ability to put it all together at once. So now we're going to start getting to some more of the nitty gritty, maybe boring stuff. So, right, health economics, what is it? Study of allocating limited resources to improve healthcare quality, access, and affordability. And those are underlined for a reason because I'm going to break down all of them as we go through. Right, if you think about athletic trainers, right, we provide quality care. We're accessible. We're extremely accessible, especially when we're placed in certain communities and we give access to our phones and people can reach us at any point. And then we're affordable, and we'll talk about how we can show that affordability while also able to drive salaries higher. So, right, those are the core concepts of health economics. I just want to point out what we're going to talk about a lot is a cost effectiveness analysis, or sometimes I'll refer to it as determining your return on investment, right? So you're just evaluating if benefits of a treatment or program to justify its cost. So our treatment or program is really going to just be an athletic trainer, okay? That will be treatment. And then in the example there, new vaccine, right? They always kind of want to see if, hey, if we do a new vaccine, is it actually cost effective? We'll talk about real briefly about number of another stat numbers needed to treat, but just those are the core concepts there for your own reading. So going back to this access and quality of care. So I just want to touch upon this real quick because we actually do have a study in athletic trainers for it. So athletic trainers' effects on population health, improving access to and quality of care. So this is actually a study done in 2019. It was actually with the high schools in South Carolina in an outreach model. And so, right, their whole goal was trying to, you know, utilize quality improvement. So make a framework and have a systematic process of, hey, we noticed these injuries occurring. We looked at our data. We did this intervention. After we did this intervention, this is what we saved. But they actually did a very good job of adding a money value to all of it. So it was actually pretty cool. So, right, create a line data system, specific program goals, multidisciplinary team. So it wasn't just athletic trainers. They actually teamed up, with the hospital system, and there was a research team. So a lot of people, hands-on stuff. They actually they had to do this. They had to kind of start evaluating their data and figure out why, like, where do we need to do this intervention? Because I guess in South Carolina, high schools have secondary insurance, and they're having a spike in their secondary insurance claims. So after they did these interventions, and I want to tell you that this wasn't a very, stringent research project and how they did these interventions. Like, they're a little bit all over, which is absolutely fine because I think they did it probably worked out better where, some of it was coach education, some of it was implementing injury prevention programs or warm-ups, which we'll talk about later. But they actually saw an absolute reduction of injury by 25%. Insurance premium costs reduced by 50%, so they're getting less hits. And, the overall theme from that article is that was that quote right there. Athletic trainers can serve as the population health leader, correctly triaging patients, providing high quality care, and substantial reduction in costs. Right. So we're kind of, and I want to point out this is 2019. This is still a relatively newer article, and it kind of took a little bit for athletic trainers to kind of start grasping this concept of health economics and, hey, how do we utilize quality improvement, access, and affordability to show, demonstrate our value. So that's the quality improvement process, kind of what I walk through. Really, that's pictures just for your own keep sinking. So, right, that was health economics, quick definition, gave you an example in athletic training and how one group already used it. But I just want to go through what is there out in sports medicine, and what we kind of find there really isn't much there either. So I just want to review one quick systematic review where they're actually looking more so at like orthopedic surgeons and doing specific surgeries that are cost effective. But what I want to break down is, right, what is a cost effective analysis, and kind of going from this, right? So the whole idea is you assess the value of an intervention by identifying procedures that lead to greatest improvement at the lowest cost, right? That's the biggest thing and theme about cost effective analysis. What intervention is the cheapest and gets you the biggest bang for your buck? So I'll try to consistently harp on that. But right, the goal is that is what athletic trainers do in a sense, especially when we're placed in a community. I just want to point out that, there's kind of been this trend towards value-based healthcare, right? People getting more bang for your buck. And and so they in this article they kind of just pointed out that people are starting, or surgeons are starting to use specific surgeries that lead to decreased costs because there's less sequelae and things happening after the fact. So, right, the biggest thing, it's value-based healthcare. So effectiveness analysis, and you'll see me refer to a couple different ways: cost effective analysis, cost effective analysis. They are all mostly interchangeable, right? But this is actually straight up out of a economic healthcare textbook. It compares the cost of achieving a particularly non-monetary objective. So generally in healthcare, they're looking at lives saved. So, athletic trainers, maybe with a lot of our pre-participation physical work or any emergency action plan, we can kind of look at that. But we're going to kind of focus on that non-monetary part. And right, we're assuming the outcome is desirable even if benefits have not been evaluated in monetary terms, like an athletic trainer, right? Everyone probably would say and believe that, hey, an athletic trainer is an outcome here that we want, right? We want someone here providing quick, easy, accessible service to the student athlete or a community or a recreational center because we believe that, everyone deserves healthcare. So there's this cost effectiveness ratio. Really, we're going to focus more on return on investment. So I'm not going to get too deep in this, but right, it's if it costs 20,000 to employ an athletic trainer and you save predicted $40,000 in emergency room visits, right, your ratio is 1 to 2. It's nothing crazy, but it makes more sense and looks better, especially for stakeholders when you present this data to break it down to a return on investment number. So that's why I kind of have that example there. For every $1 invested into ACL prevention programs leads to X amount of dollars saved from ACL surgery, treatments to quality. Okay. And we'll, and maybe we'll talk about it later, but think about what are your direct costs? Are you when you stop an ACL with the direct costs of surgery, and then what are the indirect costs of, maybe lost days at work, lost days of school, all the transport time. We'll get into that a little bit more. So, health economics, when did this actually get into athletic training, right? You saw that one article was 2019, and this strategic alliance for the research agenda. This article actually came out in 2019. So, this is where they established what is the research agenda for athletic training? 95% agree, strongly agree that health and wellness should be a research priority. So I'm going to show you kind of what the research agenda is. So there it all is. What you see on the right over there, we have health economics and health information technology. Really, the two have to go hand in hand, right? Health economics is kind of what I'm talking a lot about right now, trying to demonstrate return on investment, cost effectiveness, what money you're bringing in, are we worth it? Are we minimizing costs for patients and increasing, healthcare? Health information technology is really the way how we do it. And it's utilizing technology to be able to, create this data, be able to communicate better with people. If you're got good data, good documentation, you're communicating better with people, you're probably having better quality of care. So whenever we think healthcare economics, we need to think about health information technology as well. So just want to point out NATA, a lot of this in their work now. So NATA strategic plan, this is goal number 4. They approve return on investment. They also have third-party reimbursement, which we'll touch upon in this presentation. I want to point out here, like if this presentation isn't enough for you and you want to see what NATA has, they also have the secondary school value model and the college university value model. So the two documents they've created, they're honestly good resources. Highly recommend. Like if you're trying to figure out salary negotiations or you're trying to get more staff at your setting, these are a good place to start. So going in, and this is actually straight out of that most recent Journal of Athletic Training, the most recent issue, Health Economics, the new language of athletic training. So this was a good editorial. Once again, I'm going to always recommend reading every article that's here. But right, athletic trainers provide preventative population health management. Right, I think we know that. A lot of what we do is prevention or injury risk reduction. Someone comes and sees us for an injury, and we're trying to stop it from becoming something big. And then population health management. If we see something and hey, maybe that's not us anymore, we'll refer out. When we're in high school, it could also mean talking to guidance counselors or nurses, or even talking to parents like, hey, you need to go to your primary care for a certain illness or something that's kind of out of our scope. Coordination of care. Yep. Right. We coordinate care. We get people to the appropriate care, appropriate doctor, make sure we're getting them to, maybe a knee and hip specialist as opposed to, your general primary care physician. Comprehensive services for prevention and recovery. Like I said, we already kind of do all the prevention stuff, our warm up programs, taping and bracing is included, recovery stuff, showing people what they have to do to get recovered. And I kind of, what I liked about this was they kind of talked about how athletic trainers kind of, they function in a primary, similar to that in a primary care setting. It's like, right, you see us for the initial eval, we'd say, okay, can we keep this in-house? How do we appropriately refer you? And I think that is a very good way to look at athletic training as almost like an orthopedic primary care. I hope I don't offend any doctors kind of saying that, but I truly think we are. So health economics, right? There's a definition for you again. And then once again, they talk about the idea of, you have perform economic analysis, comparison of costs and outcomes of alternative strategies. And this isn't something new to healthcare. This is something that's already been done. An example is colorectal screening in the elderly, right? How much money is saved by early detection. Prostate cancer is another one. And there's going to be in the cancer world and early intervention, there's a few examples of doing it early and what costs are you saving. And kind of what I pointed out, this is a common pathway for practice improvements because in order to show your value, you got to be documenting everything. You got to be able to identify trends and go, "Oh, maybe we had an increase in shoulder injuries at football for whatever reason. Why is that?" And I'll go kind of through my own example real quickly at the end. But another way in which they also utilize it is, are you utilizing patient-reported outcome measures and then kind of comparing interventions depending on what you're dealing with your athletes. So for me personally, I don't really utilize these right now. I wish I did. I used them a lot more when I was in the college setting because I was the rehab coordinator and we would utilize patient-reported outcome measures just to make sure we were hitting everything before returning an athlete to play. One quick example of another way for practice improvements, right? Tape versus bracing. There's an article out there. I didn't really look for it before here, but right, bracing is just as effective and probably more benefit, more cost effective as opposed to taping every ankle. So I want to put this out here mainly because although we might not be doing research, but what we're doing when we're kind of trying to demonstrate your value, you're kind of setting up your own research project. So I want to make sure you kind of take into account like what your own research project to demonstrate your value looks like. So these are just general recommendations. You see Peterson and Lee 2022. I just want to point out these two guys, an athletic trainer, are really the two people who have done most of the research with health economics and what you'll find out quickly, it's maybe 4 or 5 total articles. But right, the biggest things when you're doing this, you're like, all right, what information do I need, right? You need to know what are the costs of whatever you're implementing. So for us, I'm honestly just saying the implementation is just have an athletic trainer. What is the effectiveness? So what is the effectiveness of the athletic trainer? In my own example, I don't really go through it, but if you're actually, utilizing a specific intervention like an ACL prevention program, that's you're going to want to see how effective that program is. Economic evaluation methods and findings. And what I want you to realize as you go through this we're not really talking like big statistical tests, and we're not talking multiple linear regression or multiple logistic regression. Like we don't need to do any of that. Really, we don't need to get in the weeds of the statistics, but just you need to be able to assess what is the cost, how effective is the program, and what is the benefits of that program. And then the other thing is sensitivity analysis. And I'm going to break this down. I don't really talk about much else in here, but right, just as we kind of go through, think about, okay, what is the minimal amount that my services would have cost and what is the maximum amount my services could have cost? And so, right, and what you should be thinking is the difference is it public insurance or private insurance and those reimbursement values that you're using. Talk about it a little bit more. I just want to make sure that before, like, this is kind of the template for what you should almost do in your own setting. So, what are the potential ways that athletic trainers save money? So, right, this is a good little chart that's actually out of a dissertation from Peterson. So, the last name, the author Peterson, he had a dissertation that I found that he had this in, and this is where a lot of his research articles are starting to come from. But, right, the three main ways athletic trainers have cost savings is injury management, right? If we keep everything in house and we manage return to play, they never go into healthcare, so money saved. Emergency department avoidance, right? I always talk about that's my biggest goal is just to try not to have athletes end up going to the emergency department if we don't have to. Sometimes it's necessary. Sometimes parents just pull the trigger and go anyway, and there's nothing you can do about it. But right, this is a big one. I'll give an example of what happens when you send non-emergency ACL tears to the emergency department. And then injury prevention, and this one a little bit harder depending on where you're at. But right, that's saying, all right, we have the FIFA 11 plus, and we're going to implement that in soccer teams, and we're going to see what our injury rates were before and after. And based on those numbers, we're going to show how much money was saved by preventing however many ACLs. So I'm not going to go into the injury management aspect of it. So just want to show you right some data around emergency department visits, and then we'll go into injury prevention programs. So right, we know emergency department costs more. than an office-based visit. That's why we try to avoid it. These are just a couple statistics. Half of emergency department visits are avoidable, leading to 38 billion in wasteful spending. Great. And we'll talk about this a little bit more, but lower income individuals and those with public insurance generally use the emergency department versus urgent care. I'll talk a little bit more later about why that is. Then I just want to point this out. The second most commonly seen injury in the emergency department are sprains and strains. We know those are preventable from going there. So that's why I'm always going to say do our best to not have those go. Sometimes, you do your Ottawa ankle rules or your Ottawa knee rules and they're on the old bear weight. Everyone's freaking out. And you just go to the emergency department, fine. And that's probably what happens in those situations. I also want to point out the third most commonly seen things are contusions and others. So, right, even there, 36% of what goes to the emergency department probably doesn't need to go. And a lot of that is a lot of just education, general patient education. So, right, so what are the actual total costs when it comes to this? And especially when it's for a non-urgent injury. So this will be the example of the ACL. So, right, quick quote there, Peterson et al. 2026, their article fresh off the presses, right? Anything typically treatable by an athletic trainer that goes to emergency department will result in increased costs and a lower quality of care. In that example, Lee et al. 2021, an ACL that went to the emergency department first averaged about 4,500 hours more in costs, and only 4.5% of patients in this scenario were diagnosed correctly. So, right, that's bad. We don't want the unnecessary things going to the ER because it's increased costs and people still don't know what's wrong. So, right, that's where ATs come in. We can manage and refer to the appropriate provider at no extra cost, especially when we're placed in a setting and it's an orthopedic injury. So, right, this is the article I was referring to. That's the title: National Estimates Non-Urgent Emergency Department Utilizations for Sports-Related Injuries in High School Age Population. Once again, just came out. Right, they use a national database, high school age athletes, and they actually try to determine if it was a urgent or non-urgent care or non-urgent injury based on ICD-10 codes, which is interesting. They also compared patients' insurance type and estimated neighborhood income, so they wanted to see if those were two reasons why someone were more likely to go to the ER. So just a couple more interesting statistics. 72% of the population are male. Basketball was actually most commonly seen, and 80% of the visits were actually in urban areas. So interesting. Non-suburban. That could just be an access of healthcare problem there. South region had the most sport-related emergency department visits. Public insurance resulted in higher emergency department visits for non-urgent injuries, so Medicaid, Medicare. And then lowest income had the largest use. So point out here, this is a chart that just on the left there, you got urgent injuries, and then on the right, you have non-urgent injuries. And I'll go back to that in a second, but just want to point out those with public insurance had a 39% greater odds of having a ED visit for a non-urgent injury compared to those with private. Their sensitivity model with similar results based on race. Self-pay plus whatever that other option is. I'm not really sure what the other option was in the study, but they also had a higher odds of going to use emergency department as well, which is kind of interesting to me. And I guess maybe it's because they want to go somewhere and get referred there because then they're paying twice. Those income had a 10% increased odds. Black and Hispanics had significantly higher odds compared to white patients. So what it points out is the reason why it's lowest income and public insurance, right? Lowest income typically has public insurance. The reason why this happens is that they lack a little bit more access to primary care, and they're also more likely to have trouble with follow-up orthopedic care. So that's kind of right. Lack of access to primary care, lack of access to follow-up orthopedic care. That's where athletic trainers theoretically can step in. So that's why I really like this idea of athletic trainers in the public health setting. And right, kind of point out maybe this is because of lack of access of high school ATs, and that's why kids are going to an emergency department without direction. What I want to point out of this chart at the top is look at some of these injuries that are actually that are classified as urgent. So concussion and ankle sprains are also in the non-urgent. So I would love to know what the code was, and someone else here might know. But it's, concussion and ankle sprains, we know for the most part probably don't need to go to the emergency room. Clavicle fracture, send urgent care. keep them in the sling. Honestly, if you have a close enough relation with the doctor, you don't have any radiating symptoms, numbness, tingling, loss of feeling, or anything like that, like clavicle fracture, you could sling and have them see the orthopedic the next day. So even a lot of these things that ended up into urgent injuries maybe aren't so either. So, right, just a couple other different ways to consider how you and your setting save emergency costs. So, right, study about $2,000 savings when emergency room visits are avoided. The ambulance ride itself is almost $950 to $1,350. So, if you have something that you think that you can get a parent to just drive them to the ER, do that. And then I also want to point out, in the high school setting, I'm sure we all do, we have to do EAP training, and if for our staffs, to help us out. And, can you show that, hey, I trained my staff to be more efficient in those by getting more efficient, we saved X amount of time that could have saved someone X amount of money. Just something put out there. It's just kind of more of an idea more so than anything else. So, right, going back, three different ways: case management, time, injury management by an athletic trainer, emergency department visits, and then the third way presented by Peterson was injury prevention programs. So I think this one's, makes sense to all of us. Injury prevention programs or injury risk reduction programs, what they should be called. Can't prevent every injury. It's implementing typically a warm up. FIFA 11 plus, just the biggest one utilized in soccer, and versions of it are utilized in lacrosse and hockey as well. And then there's plenty of different baseball overhead sports programs, so those are also ones that are used. They all essentially show a consistent reduction in injury if they're used correctly and efficiently. But there's implementations or there's barriers to implementation in them. So one study is less than 20% of youth soccer clubs incorporated an injury prevention program. Even when they train the coaches, only 43% have used it. So, we're kind of getting stopped somewhere from being able to actually use these programs. And the biggest thing is if you're trying to use it across, especially like in a youth soccer club, it's you kind of just have to start mandating it, and it needs to be more of a focus on policies within an organization for widespread adoption, as opposed to, unfortunately, you can't just show a coach and be like, hey, you should do this. They probably won't do it. So, right, fresh off the press article. This is once again a Peterson article. Return on investment of ACL injury prevention programs. So this actually only looked at U.S. high school soccer athletes. So this wasn't even every sport. And they kind of it was interesting because and what you'll see is a lot of these studies are using population health data. So they're going through insurance claims data, or they're comparing it to public peer reviewed articles. So pretty much what they show is if you implemented a national strategy for ACL prevention programs, the return on investment for every $1 invested in the injury prevention program, the return on investment is $7.51. Interestingly enough, and so when they also looked at this too, real quick, they're really just showing on saving costs from surgery. They didn't talk about all the indirect costs of ACL following the fact. So the rehab, the missed worked or days. So they're just looking at surgery. So in the public payers model, so Medicaid, Medicare, that actually almost didn't even break even for returning on investment. Tells you the reimbursement rates there. However, when you have the private payer model in, the net benefit was $60 million on a national level. Kind of what I talked about there before. And then I talked real briefly about this number needed to treat. It's a statistics, and I'll show you what the equation is on it in the next one. But right, 111 athletes are needed to be treated to prevent one ACL injury in this model. So just think about that. It takes a few teams to all be incorporating an injury prevention program to save money essentially. So these were really for your own use, but those are your return on investment equations. Then that number, the need to treat, is actually something off of incident rates before and incident rate after, essentially, or incident rates of using a standard warm up versus incident rate of using the injury prevention specific warm up. So what? So those are the three things outlined in literature. But what I always kind of want to point out is like, what about time savings? If a kid is coming to see me at the high school and the parents don't have to take them to a doctor's visit, like has anyone really looked into that? Interestingly enough, not really. Everyone recommends, hey, like you should when you're trying to figure out the health economic side of it, like demonstrating your value and other things saved for stakeholders, it's you should kind of look at the time. So I kind of started looking up, and this is what I did personally was look up how long does it actually take for a person to do a regular doctor visit. So in this article here, Ray et al. 2015, it's actually about 120 minutes, and that what that takes into account is your paperwork, your commute, insurance doing things, and then your actual evaluation of the doctor, and then what you got to do afterwards. It's about 37 minutes of commute time and 84 minutes of clinic time. They talked about that the opportunity cost is about $43 per visit for the parent or the patient going. And so what I want you to think about as we kind of go into, when we start demonstrating our value and what we use in our own models is how much time are you saving people from going to any of these doctor's appointments or physical therapy appointments or whatever it is as an athletic trainer. So, right, sum it all up and I'll keep harping on this. So how do you actually demonstrate your own economic evaluation and cost effectiveness analysis? And what I really want to point out, there's no single way, no statistical test to do this. The biggest thing is what is your intervention? What does it cost? What is that difference? And present it in a monetary value or in a return on investment number. And right, just remember ATs, we primarily work to prevent injuries and we promote healthy behaviors and can improve all these outcomes by stopping ER visits, facilitating appointments. Not too much research on this yet, but reducing missed school or working days, right? For the school side, if they're hurt and they go, oh, I can't make it in, they're missing school days, schoolwork. How does that affect them in the long run? And then, right, implementation of injury risk prevention programs. So, right, that's really how we do it, and I'll break down more on how it's been done more so in the literature. When it comes to cost of your program, so cost of hiring you to be able to provide services, just make sure that you're including your salary plus benefits. That's a different number than just your salary. How the cost of supplies that you get. So like if your high school's budget's $5,000, make sure that's implemented, and then the cost to implement an injury prevention or risk reduction program. Right. So economic evaluation. So what is out there already? So I'm actually going to break this down by, the most common settings that athletic trainers are in and what the research has already been done for them. So in the secondary school setting, Lee et al. 2019 looked at Oregon high schools. Once again, population health data. They looked at, medical claims data and assess the cost benefit of hiring an athletic trainer based on zip codes and where these claims were occurring, and they would have to be high school age sports related population. So what they actually found that there was no cost saving with hiring an AT, especially when it came to if you're using Medicaid or Medicare claims for reimbursement for them or for their salaries. But the limitation here is that this was actually done in an outreach model, right? So, think about a hospital healthcare system having an athletic trainer just stationed at a high school for after school practices only. Research study 2016, actually full-time high school athletic trainers in the setting that I'm in. I'm a full-time athletic trainer in Baltimore City. They actually reported higher overall injury rates compared to those in outreach model. It was 3.6 times. So, right, are kids getting more injured with an athletic trainer? No, we're just there actually evaluating everything that comes through the door, and that's the difference. So this is actually another high school study. This just came out. I was looking at costs for athletic training services in secondary schools for knee and ankle cases. I want to point this out because it does give you a number about what each case could be, how much money and services you provide for each case. National database, Datalist for anyone who's ever participated. Datalist is this national database that people do. So, recorded services for each injury. Is knee and ankle cases from 2014 and 2019. I want to point out a lot of the data stops at 2019. I've been assuming it's a COVID thing, but just to think about for any of this and the inflation that's probably occurred afterward. But ankle cases 148 hours, knee cases 124. Those numbers were actually lower compared. There's another research study. Another database, the Athletic Training Practice-Based Research Network, the costs they have are a little bit higher. I didn't put it in this presentation, but that's what this article said, and I put this quote in here because the limitation is honestly it's just our documentation, right? And I'll read it real quick. Quality of patient care documentation in athletic training is inconsistent and influenced by a number of perceived factors, including lack of expectation and accountability, low prioritization, lack of time, and uncertainty. Consequently, ATS's athletic training services may be underreported and are difficult to accurately describe. So what they're saying is that athletic trainers just weren't documenting everything that was occurring, and that's why the costs are so low, right? So I also put this in here from the article mainly because these are all the CPT codes and the average fee. Like this is how they did it, right? They said, hey, they did one massage for that ankle. The fee for that, the typical physician fee for that is 27.69. So that was the cost. And that's how they kind of determined the cost for that. Okay. So that's all there is in the high school setting, right? Those two research articles, and one just came out last week. So industrial setting, right? And I don't know how familiar you guys are. I worked in it for 6 months. I'd still do per diem, but your main thing you're doing is prevention, right? You're going around, make sure people aren't doing anything unsafe. You're doing ergonomic assessments. Where I was at, we did regular, like for new employee orientation, we followed them at 30 day, 60 day, 90 day, and had our whole thing. But right outside of that, it's very little rehab and emergency care management from a rehab standpoint. I'll call it more case management, right? Kind of we talk about is like make sure we're going to the right provider. What can we do? Can we keep it in house whenever we can? So interesting study, Olchi et al. 2018. They kind of looked at all right, athletic trainers got hired. What were the workers' comp claims 2 years before and then 2 years after? Quick note: when it comes to the industrial setting, the biggest thing is stopping workers' comp claims and stopping OSHA recordables. Okay, right? Cost decrease almost by half. Light duty days, because that would, if someone gets put on light duty, that's OSHA recordable. People don't like that. Those got reduced by half, and then lost days decreased by 37%. All of this kind of helps just help with employee retention. The longer they have people there, the less they have to hire new people. And it's pretty well known in the industrial setting that the new hires are typically the ones that are getting hurt. And so, right, that was one study showing athletic trainers' role in the industrial setting. NATA actually had a survey. It's very, very interesting. This was specific to return on investment. So 100% of companies reported a positive return on investment, 80% $3 return on investment for every $1. 85% reported 25% decrease in total number of injuries and costs. Employees' days of work decrease. ER costs reduced by a lot. And a lot of that is just because some companies, prior to an athletic trainer coming through, their process is every injury goes to the ER urgent care, so that's why they would get dinged pretty hard. Right, 96%, almost every company reports a decrease in workers' comp claims after 1 year of an AT employment. So this is kind of just what that survey had, and what I wanted to point out was, right, honestly, the majority of them reported kind of what it said, 3 to 5, 5 to 7, and even more than $7 for every $1 invested into the AT program. So, right, this article actually just came out, and I honestly highly recommend reading this because it really breaks down, right, that how to demonstrate your value, the keeping track of your services, how you would use CPT codes and say for that amount, that service, you would generally get reimbursed or billed this, and that's how we save money. So breaking it down, so this is actually looking at a warehouse with 300 full-time workers, 100 temporary employees. The AT was there 1 day a week, 4 hours per day. They were almost not even there. And I really want to harp on that, especially in the industrial setting, because they're able to kind of demonstrate how valuable an athletic trainer is when where they're really only there for once a week. They incorporate direct costs. So, right, direct costs is what I keep talking about. What is the cost of your service, as well as indirect costs? Indirect costs is kind of stuff like that emergency room department avoidance, or the time savings measurements, or what they use here is the indirect cost of lost production, damaged equipment. A lot of companies will hire private investigators, and then there's lawsuits because someone got hurt at work, so now they're suing the company to get whatever money is deserves to them through workers' comp and whatever it is. They actually just kind of use a general 5-to-1 indirect cost ratio. So whatever the direct cost is, the indirect cost is five times that, which I thought was actually then that's pretty standard in the industrial occupational setting. So right, there's 287 encounters. An encounter is like kind of anything. You talk to a guy on the floor, that counts as an encounter, especially if it's around like sleep or anything that's health related. The estimated direct cost, so all the services, 164,000. What that came out to with the indirect cost was every $1 spent on the program saved $6 for the company. So, and that's the return on investment formula that was utilized in that article. So, right, we did high school, we did industrial, and next we'll do military. And what you'll find out, there's a reason why if athletic trainers work in the industrial military setting, the salary's a little bit higher. It's because they've done a better job of being able to demonstrate their value and show return on investment. So we got two research studies. Fisher et al. 2020. It was over a 2 year period. I just want to point out these athletic trainers were were new grads, so you can even throw experience out the window about how effective an athletic trainer is. But the but there were pretty much there was a control squadron where there was no athletic trainer embedded, and then there was one squadron that had two athletic trainers that were oversaw by a sports med fellow. Those with ATs, 25% lower risk of injury and related attrition, and 15% lower all cost attrition. So right, attrition is someone dropping out of basic training. This is kind of what they're looking at. We're this was at basic Air Force basic training base. And attrition's huge because, right, with that, over a 2 year period is about 10.5 million net savings for the US Air Force. The reason why that's big is when someone enters basic training, they have to pay someone to go to basic training. And the estimated number is about 30,000 is what it costs every time someone drops out of basic training. So, right, it doesn't take stopping that many people from dropping out to kind of rack up the money. So what was interesting, right? There was increased diagnoses of pain, inflammation, and lower extremity injury. But once again, I think that's just athletic trainers identifying it first and stopping it from getting to a point where they could get more hurt and have attrition. And interestingly, too, they had a whole gait screening analysis here, and lower extremity stress fractures were reduced. They also had improved fitness score, which is great. Another study, a little bit more recent, but they actually looked at older data, but it was the same idea, but they actually had a kind of more of a breakdown. There was a control group with a part-time medic, there was a full-time medic, and then there was a group with part-time athletic trainers that was only 20 hours a week. Kind of what I said. But it was interesting, compared to the full-time or part-time medic, ATs had a significantly higher odd of returning a soldier to duty. The implementation of this program, once again, it ended up being about the same, that being a 10.5 million in net cost savings for medical care. So that's why in the military setting, it almost becomes a no-brainer to hire an athletic trainer. And right, their return on investment was $9.48 for every $1 invested into the program. So another common setting that we're all at is physician extender setting. And so to be honest, it's only one study, very recent, just came out. It was online first originally. Uh, and kind of looking at how athletic trainers were able to bill or be reimbursed while working underneath the physician. I want to say it's University of Wisconsin, but don't hold me to that. So they actually reviewed claims over a 15 year period. Uh, Athletic trainers have a similar number of visits compared to PTs, OTs, PTAs. Over that time, those are your numbers. ATs billed for 14.3 million, or about 95,000 a year, and were reimbursed for 11.4 million, about 76,000 per year. So I put the per year numbers just so you kind of think about what the annual salary should be in those situations. A limitation is, right, athletic trainers, when it comes to insurance, are not recognized by Medicaid, Medicare, so they're actually limited who they could treat. So in this setting, they didn't treat anyone over the age of 65, when the age of 65 could have been a large group that ATs could provide service to. So I kind of held this out for last. College sports professional setting, you're more traditional, and the main reason why is the studies are lacking. No one's really published the return on investment for these, and I'm sure a lot of colleges professional settings have something internally, but no one's really looking at it or publishing it. And it could be I just couldn't find it, but I tried. Uh, I just want to point out maybe some additional ways besides what we've already talked about. How often can you reduce your secondary insurance claims? That was kind of a big thing where I was at University of Delaware of, hey, can we not have something hit the secondary insurance if we don't have to? And that can be a huge cost saver. What about time loss reports and NIL money, right? I don't know how that all kind of interplays with in the college setting anymore, but just a number to think about that maybe implement in your own setting if you're in the college or professional sports setting. Article just come out, right? In this latest issue. This is interesting. So what this article was really about it was D1 is University of South Florida. Their athletic training department is underneath the Department of Family Medicine. So they're directed by a physician. And what they decided to do was, hey, can we all get on the same EMR, electronic medical records, and can we figure out a way to have be able to get reimbursed for our services through billable encounters and a physician directing the service? So multi-year study here, and this is just these were units billed per year, and then these were how much revenue was collected. And what I want to point out, right, you see those numbers down below there. And I'll walk you through it real quick, right? It looks like, okay, one person tried doing it. The second year, okay, two people tried doing it. Okay, and this is what essentially happened. We're going to train the entire staff, and everyone's going to start being required to do this. And so, bam, you get that 38,590 number. And then the next year, it drops precipitously. And you probably go, well, what just happened there? It's college athletic training, high turnover rate. So, and even then, what I talked about documentation before is that athletic trainers just don't do a good enough job with it. So they weren't getting reimbursed on a regular basis because it wasn't happening. And also with athletic trainers, there's many non-billable encounters, right? This is only billable. So they had to go see the physician first, get a diagnosis, and then essentially get referred back to the athletic trainer to do rehab. So I'm sure they didn't really go into deep into the weeds of why this happened, but part of it was they had all this training that they have to do, especially they were using hospital system based EMR, Epic, for anyone that's familiar. So they were kind of getting stuck with how to implement. And then once you have staff turnover, that's all the training you have to do over again. This is really just for yourself. This is just how they determine billable encounters. So, right, once again, why is all this important? Just want to refocus, right? There's folks on salary compensation. It's one of the NATA's research initiatives. And what I really think is cool, it's kind of showing the athletic trainer's role in the public health setting. How do we generally just help disease and injury across the lifespan? So right, that's all the research, and so we're getting to the tail end of this. It's going to be very quick because it's kind of building your own workflow and kind of some things that you need. So technologies and skills. I personally don't think it's much, but right, as long as you have access to the Google Suite, it's free. Just some willingness to learn. Make sure you got Google Forms. Your Google form will automatically go to a Google Sheet. From the Google Sheet, you can really make pivot tables, and I'll talk real briefly about it. But if you're really into it, you can actually make a dashboard through Google Looker Studio, which is Microsoft's version is Power BI for anyone familiar. So, right, you need your Google Suite, your EMR system. So some have the ability to put a value on your treatment costs and athletic training costs. I just prefer kind of using a Google form. We use it as like our sign-in sheets because that could be something that you put off on the student athlete to sign in, and you're able to automatically have this stuff happening. Might just save you a step. Okay. So things to consider, right? Make it as least obtrusive as possible, right? If your EMR makes it very difficult to document on the go, right? That's kind of what mine is. We have ATS. It's difficult to document on the go for us, so that's kind of why I and we at Baltimore City utilize Google Forms. Um, utilizing utilize your Excel, Google Sheets to automatically calculate and create dashboards. There's a way to really automate this process. And then the biggest thing, especially if it's for department wide and whatnot, I'm not the overseeing athletic trainer at Baltimore City. I'm just one at high school. But it's really important is we've had a lot of discussions, and the idea is standard operating procedures. And it's to make sure that everyone understands what needs to be documented every time someone walks in the door. And it's very important that every time someone walks in the door and you put your hands on them or you talk to them about something, that is an injury evaluation, okay? And making sure you're doing everything you're supposed to do and documenting appropriately. So, right, what are some values to keep track of in your setting? Right, what are your services? Evaluation, follow-up, rehab, treatment, etc. Field coverage. So I incorporate this in my own number, what no one else had, but right, if I got to be outside for 3 hours today, how much will it cost for a per diem athletic trainer to be out there for emergency costs, right? So that goes into my equation. Time savings, and I have another slide here about how to do that, but right, it's just going to be how much time would someone it cost to go to a doctor outside, and then I multiply it by the median hourly wage. So That's more so, hey, if a parent has to take time off in order to take their kid to an appointment, that's money they're losing. Okay. Saved ER visits. I actually don't utilize this in my own numbers. I just haven't figured out a way to make it consistent, creative enough to make it automatically happen. Time loss, especially if, there are bonuses or NIL money involved. So time savings measurement, right? Estimate time for appointment times local median hourly wage. In Baltimore, it's between 26 and 35. It's just whether that's the Bureau of Labor Statistics, which is actually 35, or the private sector has it at 26. So these are the common CPT codes that I use. So right as you see, like right, I'm trying to make it as simple as possible. So it's initial eval, follow up, therapeutic exercise, manual therapy. In what I do, I actually don't even so right initial eval and follow up, that's one service. You can only bill it one time. Where therapeutic exercise manual therapy, it's per minute. So if you have someone doing a full ACL rehab, you could probably like it could be 3 units if they're there for 45 minutes of therapeutic exercise. I'll be honest, in my setting, I don't honestly get to do that too often. And I also, even if I do, I like being a little conservative in my measurement so that, what we talked about for that sensitivity analysis, we can kind of always pump up what that number looks like. And what I put there, right, there's the Medicaid reimbursement rate, and those are the numbers that I use. But generally, you could use commercial insurance reimbursement as well. It really depends on your population. Like, if you're at a private high school, there's probably a higher chance that there's a commercial insurance reimbursement as opposed to Medicare or Medicaid reimbursement. So, pointing out here, I've talked about it, but right, documentation, data collection, huge, important. You just have to be on top of it and be able to time and manage your skills. So only 46% of ATs report always documenting athletic training services, right? You just got to be better. They cite time, lack of resources, no continuing education past undergraduate or graduate program, which to be honest, I agree. I'll be honest, I don't really think I learned how to document appropriately and efficiently until I was in grad school and past grad school. And right, a lot of people don't have an efficient system. So you have to figure out what that efficient system is for you. These are just a couple examples. Make sure whatever you're using is HIPAA compliant. Even if you're using the Google Suite, it should be if it's through an organization, but just make sure you de-identify the data. So this what the framework looks like for what all the costs is that you're providing. Okay, or what you would be reimbursed. So, right, cost of services provided, that's your evals, your rehabs, etc. Time saved for families, avoided travel times and lost productivity, and then right, field coverage. So those are the three numbers I use and we use at Baltimore City. Harder things to track, but to consider, right? EAP training for staff, pre-participation exams, especially if you're setting it up at your high school. We do a lot of that in Baltimore City. Phone communication, like if you're truly following up with a kid in a college setting and having them make sure they're doing rehab and whatnot, there are actually reimbursement codes, CPT codes for that as well. And then, right, physician referral appointment setup, like how much time are you saving by helping set up an appointment? Uh, I guess I could say I'm pretty much taking that into account with that time savings measurement, but you could technically make it a separate measurement. So, and I just want to keep pointing out there's no exact way to do this. Variations, there's going to be variations cost of service based on where you're at, how thorough documentation is, and nuances to your specific setting. And right, you're not going to get reimbursed for everything. Like something happens, like that one study showed that it was billed 14 million, but reimbursed 11 million. You're right. Consider utilizing sensitivity analysis to show that lowest and highest potential costs. And yeah, I'm talking a lot of money value and all that, but like I do want to point out like what are the outcomes? At the end of the day, we want to show, hey, we're providing, exceptional care for a population that maybe wouldn't have gotten it. Maybe they just wouldn't have done it. In Baltimore City, we deal with kids that they just don't go to doctors. They might not have insurance. They would have never gotten the health care anyway unless we were there. Just a couple other things to kind of think of that you could utilize in your own setting. So right here is my example. So right here's my Google form. All the basic stuff: sport, body part, side. What's the visit reason? Was the parent contacted? Was there a referral essentially? And then was it urgent care or EI or ER referral? So right, this is the a video really just of me of what that Google form looks like, right? That's more activity probably should be a drop down. But the biggest thing is don't make it stuff that you type in. It should be stuff that's already preloaded so that when you do your data, because right, think about this, even from this, you can kind of determine, oh, how many knee injuries did I have? How many were right, left? How many parents did I contact? You can get all that through a pivot table essentially. So sorry, I gotta figure out how to get out of this. Uh, there it is. Always there. So, right, your Google Excel sheet, utilize a pivot table. If you don't know what it is, look it up, figure out how to research it. And I'll be perfectly honest, how I learn a lot of this stuff now is I just ask ChatGPT or Gemini, just ask an AI and it'll treat it for you. If you want treatments per day per week, I'll show you some extra Excel functions and I'll just use another tab to track your practice game coverage so that you can figure out what your field coverage or per diem rate coverage would have been. So this is what my Excel sheet looks like, very, very raw. Looks just like a bunch of jumbled numbers. But the red box there shows you, oh, that's the numbers I'm using for costs for each thing. So as you see for tape, I put 10, wound care, I put 5, because generally those aren't things that you can get reimbursed for, but it is time and resources being used to it. Um, Functions to consider using learning, just put in these here. Like if you're really getting into it and you want to really automate your process and create a dashboard, these are some functions you should learn. Like if you're really good, that's what it looks like. Very minimal words, not super long function. Don't worry about this if you don't care to learn it. Uh, Time saved equation. So, right, that's what I spoke about before. So, right, I talked about services. I do my time save equation. For me, I use 3150. I took the middle and I multiply it by time. Um, Chart creation. So, right, because even if you have all this data and you can't present it effectively to stakeholders, what does it do for you? So just make sure you include the basic stuff. And like I know it's basic, but like chart title, axes titles, units, clear category descriptors, the important is just make sure it looks like you can understand it. So, right, this is just all the data I'm presenting here is just based on this past fall. Okay. I have numbers for the past year. I just felt like this past fall, they're honestly better numbers because I've been there for more a year and more kids are seeing me. So, right, I evaluated a total of 281 injuries this past fall season. Last fall is 146 injuries. So just there alone is 92% increase in injury evaluations. Once again, that is mainly because they were just seeing me more. Reasons for follow up. So right, these were my clinic reasons. As you can see for me, the biggest thing was initial evaluations, follow ups, and tape. And then, you know, other is really just I would call those consultations where I talk to a kid and determine return to play, but didn't really feel like it warranted a hey, that was a billable AT service. But this is what it is for me, and for anyone else, it could be different. The rehab exercises could be way more if you have more athletic trainers. I feel like if we had a second athletic trainer at Poly, these numbers could easily be way more. Um, Cost of service by sport. So, right, this is just showing that hey, my fall sports during the fall cost the most money, and football really utilize my services more than anyone else, which makes sense. So, what did this breakdown and return on investment cost look for me? So, total cost of services about 42,000. Total time saved. Total and right, you have hours. You have to convert the hours to minutes. So that's kind of what I did. I made sure it was more of a you had to convert it to minutes, convert it back to hours essentially to get that. Okay. Total cost savings from time, right, was about $24,000. Number of practice slash game coverage hours, 254. I made the per diem rate 55. So total cost savings for families in just the fall, talking about just the fall, was $80,122. Total cost for AT services for me for the district was 23. Return on investment to taxpayers, the total number is 56,782. You could all call it whatever you want, taxpayer, societal. I call it return to families type of deal. And so essentially in the fall alone, for every $1 invested in AT services at Poly, it was $3.43 return to Poly family slash society. Just want to point out here, there's actually, wait, I had these earlier in the presentation, but it's actually a couple different return on investment equations and they'll get you different numbers. So that one I used was more like that one in the middle, just medical costs prevented divided by implementation costs, the implementation cost being hiring me. But that number actually would have been lower if I used the other one, the one below. Just make sure you realize there's different ways to skin the cat. And right, so you've made that, all those charts. The biggest thing is after you do all this, make sure you create a report or a dashboard that you can show and have an explanation of why certain things are happening. Okay. So I've started utilizing a dashboard that I can just pull stuff from Looker Studio. So this has all the same numbers. I took it at a different time, so the numbers are a little different. But just want to show you that this is something that you can easily create. And this is actually like living, breathing. It will update as data gets put in. So, quick reminder, honestly, for this is a little bit over time, but right, why are we doing this? Put a monetary value to what we do, show everything that we do, uh, show that, hey, I'm not just here and waiting for an injury. There are all these things that I'm doing. It's going to force you to improve your documentation and data, which is going to lead to better quality patient care. And you can't really have discussions over salary negotiating, staff expansion, etc., if you don't have the data to back it up. So just a couple future considerations for your area, things you could utilize. I'm not going to dig into it, but if you're already doing this and you're thinking about what to do more, think about utilizing patient-reported outcomes or clinician-reported outcomes because that's now you're really digging into the weeds of how to better improve your own practice. And future directions of research, not going to get into it. Kind of already over time for my presentation, so we'll see how this goes live in person. But right, just want to point out here are some additional ways to reach me and other things that I do. And then those are the references. And that is it. So this will get published as a podcast, and I guess I'm saying it at the end, so it doesn't really matter. But that's it.